Good evening. Welcome to another episode of Fresh Natural Live. As usual, we have a great show for you tonight. It's Monday evening. It is March 14th, 2022. And we're going to be talking about hypertension. It's a common disorder that I see in my practice. And I'm going to talk about some simple things that one can do to naturally control their blood pressure or control the hypertension, while at the same time decreasing medications. And I'm going to share with you some basic info on hypertension and share some information about a particular patient that we help with managing your hypertension. So I think you're going to get a lot out of this show. So sit back and get your pen and pencil ready. We got a lot of information for you. Okay, welcome back. So as I was saying, we're going to be talking about hypertension. And, oftentimes patients will come and they say, well, doctor, do I have heart disease, or what's the condition of my heart? And of course, we'll be managing, their high blood pressure, or they have a diagnosis of hypertension, or they're on one or more medications for hypertension. And, typically, especially if the high blood pressure is not well controlled, I'll say, well, you have hypertensive heart disease, or hypertension, which is a contributing factor to cardiovascular disease. Really, when you think about someone who has an elevated blood pressure, the elevated blood pressure in and of itself is an abnormality. We treat it as such. However, we also have to understand that the elevated blood pressure is a signal to one of more abnormalities that's undergoing at the biochemical, the cellular level, the tissue level, the physiological level. For instance, individuals who have elevated blood pressure may have abnormal adrenal gland function, abnormal thyroid function. They have vascular disease where the blood vessels are stiff. Of course, cardiovascular disease, the heart may be thick and stiff. And that may be creating to poor compliance in the cardiovascular system, and hence the blood vessel may be elevated. There could be metabolic things that can contribute to elevated blood pressure, mechanisms that we don't fully understand. They may be related to metabolic issues related to insulin resistance. Insulin resistance, as we know, is the underlying mechanism that contributes to type 2 diabetes. However, elevated insulin levels, which is found in insulin resistance, the insulin molecule hormone itself behaves like a growth hormone. And so you can have smooth muscle proliferation and myocardial thickening and stiffening and fibrosis. And these things may be contributing to an elevated blood pressure. So an elevated blood pressure in of itself, I like to think of it not only as an abnormality, but as a signal or an alarm, if you will, of other underlying conditions at the tissue level, the cellular level that's abnormal. So when we think of controlling or treating high blood pressure, yes, it's good to maybe prescribe a medication or an agent that's going to decrease the blood pressure, decrease the number. But we also have to consider the underlying metabolic processes that are at play, and that's why I like to use nutrition as a therapeutic intervention. So what I'm going to share with you today is a little bit of information about hypertension in general, and I'm going to describe a patient that we saw recently, whom we've been seeing for about a year and a half or two, managing hypertension, and we will share with you some of the things we're doing recently when she came back with suboptimal blood pressure control. And then this is going to get into some of the things we've talked about before and some of the therapeutics. So anyway, just as I get in there, I see my colleague, Dr. Celeste Palmer, has joined. So I'm going to welcome her on before we get started. Dr. Palmer, how are you doing? Welcome. I know you've been saving lives today in the pediatric arena. But anyway, so as I'm sure you heard backstage, we're going to be talking about how to naturally control hypertension. And the important subtitle is while reducing medication. So many of you who either have high blood pressure or know someone with high blood pressure, you go see a doctor, and we're constantly adding medications. And one thing I'll mention is that individuals who may be diagnosed with a metabolic condition, particularly insulin resistant or type 2 diabetes, oftentimes you'll get prescribed an angiotensin receptor blocker, an ACE inhibitor, and you're told that it's meant to protect your kidneys. We'll talk about that a little bit later. So if anybody has a question about that, put it in the chat. But I think that's an important thing to discuss as we toward the end of the show. So how to naturally control hypertension while reducing medication. I think while reducing medication is a critical factor. Let's get into this whole concept of hypertension. In 2017, the ACC gave the definition, and the definition of hypertension is kind of moved around, and I'll share my thoughts on that. But the definition by the ACC was 130 over 80 is the limit. Now, this used to be hypertension for diabetics, and it used to be 140 over 80 or greater than 140 over 80. Or I think greater than 140 over 90 used to be hypertension, but now stage 2 hypertension is 140 over 90 or greater. And the stage 1 has been reduced to 130 over 80. So these numbers go back and forth. And I'm not going to get into that because, when you ever you do something by committee, you oftentimes have a hard time defining things.
And can I just throw in something real quick?
Sure. Yes, please.
It changes, just so people know, it changes for children too. It's lower for children.
Oh, okay. What is it for children?
I mean, 90s over 60s, 70s is for a 7 or 8 year old.
Wow.
Yeah. So the 120 over 80 for a child is pre-hypertension.
I've seen a lot of young. So, what if I see? So I've seen some teenagers, 16, 17, come in with blood pressure 130 over 75, some 120 over 85. So they're kind of early hypertension then.
Yes.
Okay, that's good to know. And so what we have here, these are the standard numbers, and I give you this largely because you can take a screenshot. But the numbers change for us, and as Dr. Palmer said, they change for pediatrics as well. But I like to emphasize that these numbers are resting, blood pressures, and so you should take a blood pressure early in the morning, one before you go to bed. When you're out and about moving, your blood pressure will go up. I like to see activity blood pressure not much higher than, say, in the 140s systolic and 80s and 90s diastolic. Really like to see the diastolics on the low side. Normal physiological response to exercise, that the systolic goes up and the diastolic goes down. If the diastolic's going up, you're probably dehydrated. And so a lot of people with these elevated blood pressures, oftentimes dehydration is a simple contributing factor. Not meaning that there are not more complex mechanisms also contributing, but dehydration plus other things are contributing. So just by hydrating yourself, you can probably at least control some aspects of your blood pressure. And then, to get other parts of your biochemistry, physiology under control, you may have to do some of the other things we'll talk about today. So generally speaking, it contributes to high blood pressure, contributes to heart disease and stroke. It's probably one of the leading contributors to both of these. In other words, people have, hyperlipidemia, diabetes, et cetera. Most of the time they have hypertension in addition to one of these other comorbidities. 2019, more than 500,000 deaths in the United States had hypertension as a primary or contributing cause. Only about 24% of Americans with hypertension have it under control. And when we say under control, we're talking about under control with medications. And today we're going to talk about under control in a different manner. About half of adults, 45%, have uncontrolled hypertension, have a blood pressure 140 over 90 or more. It's really interesting because I'm part of me is kind of immune to these elevated blood pressures. I see 140 over 90, 150 over 90, 150 over 100, 160 over 100. And I'm not shocked because I'm seeing these elevated blood pressures, 180 over 100, 200 over 100, 200, and I've seen these people walk around with these blood pressure for a long period of time, and so which is not bad because your cardiologists get kind of used to seeing these elevated blood pressures. These are when they come in as new patients, but we do help them get them under better control, and we'll share with you how we do that. About 34 million adults who are recommended to take medication may need it prescribed and start taking it. About 2/3, 19 million, have blood pressure 140 over 90 or higher. And the cost is great, $131 billion each year. The biggest contributing factor to our ongoing debt is Medicare. It's over $1 trillion a year. And so that's something that we have to be mindful of. And cardiovascular disease is a big contributor to that, and heart hypertension is a major component of that. So, there's a cost to us individually, but there's a collective cost to us, certainly for our economy and ongoing debt. Here's this little map that shows areas. So there's a geographical distribution where you see in the deep south, we have the highest prevalence of hypertension. Now, some people attribute that to the diet, lots of fried food. I mean, here's the state of Louisiana and Alabama. You know what they eat in Louisiana. Louisiana probably should have its own shade. So I think if they broke it down even more, they probably have a little darker red or something like that. I'm going to welcome on Dr. Pam Atkins, who just joined us today. Dr. Atkins, how are you doing today?
Hi, good evening. I'm doing great. Sorry to be late.
No problem. So as I was going through some of the epidemiology of hypertension, we have a deep distribution sort of in the South, and the South is known for like a lot of the the types of food, the fried foods and things like that. But they eat bad food all over the United States, so I don't know. But a lot of African Americans, Black Americans are in these states. So you may have if you did a racial distribution, you probably see Black Americans and Latino Americans in a lot of these areas too. Black Americans in particular having elevated blood pressure. So that may be a genetic.
But it may be also, if you look at the states that do, they have the list of states that exercise more. And so maybe those are the states that don't get out and about, nature walks and things like that.
That's true. But I don't know. You get some of these other states here that are cold.
But they have a lot of nature up there.
Yeah.
A lot of nature. There's a lot of outdoor activity up in, Montana and Utah and those places. Even though it's cold, they still go out. They still go out,
yeah. And these people just don't go out. So I guess it's a matter of the elective nature of people going out and not going out.
Because I'm saying that because, we also are in California. If that was the case, then, California should be.
That's true.
Darker.
Yeah, that's
color,
true.
Versus we know that they're outdoors people.
Yeah. And I guess the question is, why are they outdoors here? There should be any reason why. You probably have some of the best weather here. Even Florida has some of the best weather. Now, they're not as dark gray as Louisiana, but you think they go outdoors here. Same in Texas. I agree with you. It's just that, these places should be as much outdoors as any place. I guess it's just people electing to go outdoors. I don't know. But I think there are multiple factors. I think what they eat down here is probably different than what they eat up here. I don't know. They're probably eating more wild game here. I'm not disputing the outdoors factor.
I think, like you said, I think it's multiple things.
Yeah.
I don't want it to just be because of, race that you can really break that apart.
Yeah.
I wanted to correct you on that.
So don't tell me not to be a racist on it. Well, the thing is that there is a genetic. So my cardiology fellowship, I published an abstract and presented at ACC. And we know that Black Americans have an increased amount of the deletion allele for renin-angiotensin. So we have a greater expression of renin-angiotensin at the cellular level than at the tissue level. And so that's, Black Americans. If you look at Blacks from countries in Africa, some of the people publish that they have even higher, where they've not intermarried with other races, they have even higher prevalence of this genotype. And so, which is a major contributing to renin-angiotensin activity. Now, so that increased renin-angiotensin activity give us a higher, so for any given level of blood pressure, and they've done these studies where you have Blacks versus whites, you have a greater amount of left ventricular hypertrophy for the same amount of blood pressure. So let's say 140/90 across the board, Blacks will have a higher amount of hypertrophy than whites. So there are biochemical differences that have been defined. There's also related to salt sensitivity being greater in Blacks, and you can attribute that to, we're supposed to be in an area near the equator where we should have a greater salt sensitivity eating a lower salt, diet and so on. So that there have been genetic and biochemical differences that's been clearly defined in Blacks and non-Blacks.
But then the question is, what is normal?
Well,
I mean, let's take out the fact that, a lot of us have multiple underlying conditions that kind of contribute to our health deficit here.
Yeah. Uh-huh.
But in other countries, if you look at people of African descent, what their average blood pressure is and what their overall health outlook is. I don't know the answer to that. That's just
yeah. I mean, normal can be something that doesn't give you end organ damage. I mean, so it doesn't give you stroke, heart attack, kidney failure. So it's going to be over the course of time. I think biologically and physiologically, and these numbers, we just threw up, they're, as we said, the definitions are arbitrary. And I think to your point, normal has there's a biological norm, a statistical norm, and all of that. But we do know that there's a correlation or association with these higher numbers with disease states. Having said that, as I said at the outset of the show, elevated blood pressure in and of itself is not the only problem. Elevated blood pressure may be a signal of an underlying biochemical physiological imbalance. And so I think that the imbalances of what we need to talk about, think about, I should say, in addition to the abnormal number. Because oftentimes we just treat the number and we don't think about the whole person. And so in terms of, okay, here, take your calcium channel blocker or your diuretic or beta blocker, and the number's normal, okay, that's great. But the diuretic is causing dehydration, the diuretic is causing magnesium deficiency, the diuretic is causing other problems that, physiologically it's not, boding well for you. And over time, you then end up with renal failure. So renal failure due to hypertension, well, the hypertension is controlled. But you're on 4 medications, 3 of which are contributing to renal failure. So, but anyway, yeah. So this geographic difference here does raise questions. I agree there are other factors, lifestyle, getting out, but I think the racial difference has been defined, and we have to, consider that in addition to Dr. Atkins.
Yeah, I wanted to say something. I think it's interesting that you said that left ventricular hypertrophy occurs at a lower blood pressure.
Or equal, greater LVH at equal blood pressure. So Blacks will have a greater amount of LVH at equal blood pressure than whites. Yeah. Right.
So with white and Blacks, but at the same blood pressure, Blacks may have affect what we're saying is a larger or thickened heart or left ventricle. And so we're seeing, that says to me that we should be a little bit more aggressive in screening and being proactive in preventing, because we can get in organ damage sooner.
Yeah.
So that's interesting, to me. And as far as the states with particularly in the South, it always goes up to Indiana. But I think there's a lot of cultural ways we eat. And, especially Louisiana, Alabama, Mississippi, culturally, it goes on to other states. And many of these people have moved up north. But culturally, the way we eat, has been a factor in, our health conditions, chronic conditions like hypertension. And it's very cultural. And we know Louisiana, and everybody loves that type of food, but it's part of their culture.
I was looking at some relatives on Facebook pictures of eating some bad food. I said, gosh. But the cultural thing is, people say you need to be culturally sensitive. I said, well, just change your culture and I'll be more sensitive. So let's get into this clinical intervention. So we have a 68-year-old female. We'll have to use that line on the patient. With long-standing hypertension, diabetes, and hyperlipidemia, thyroid disease, and paroxysmal atrial fibrillation. And we've been treating this patient for about a year and a half or two. And so she came in recently with suboptimally controlled blood pressure and symptoms of feeling fatigue. Now, I'll say at the outset, this patient had gone through a detox before and had been back and forth on the diet. And recently, she'd had some stress at home and kind of fell off the wagon, jumped off the wagon, however you want to, state it. But she'd had some success before with our, food prescription approach and so on. But she reports having increased amounts of stress at home and her blood pressure has gone up. And it was on the same medication. She had not undergone significant medication changes over that year and a half for the most part. So the medication list was as follows. Edarbi, which is an angiotensin receptor blocker, it dilates arteries. This is probably the last brand angiotensin receptor blocker out, and probably the strongest one based on head-to-head studies that they've done. And she was on Eliquis, 5 milligrams. Now, these are actually her current medications. And actually, this slide, let me ignore this slide. So I messed up here. When she came in, she was on Edarbi Chlor. So Edarbi Chlor was Edarbi plus clothalidone, which is a diuretic. She was on Carvedilol, 25 milligrams. She was on 81 milligrams of aspirin, and she was on metformin, 500 milligrams twice a day. And we had decreased that. So these are actually our latest medications. I'll show you the change we made in the next few slides. So remember Edarbi Chlor, so Edarbi plus a diuretic. So that's two medications combined. Carvedilol is 25 milligrams twice a day. Aspirin, 81 milligrams, and metformin was there. And she was on Eliquis because she has atrial fibrillation. So that's a blood thinner. And of course, vitamin D and magnesium. So what did we do? At that time, she underwent the standard cardiac evaluation. Patients come in with fatigue. She had not had an echo before. She had an echocardiogram. It did show LVH and a heart that squeezes normally, but a thick left ventricle. And her blood count was okay. The cholesterol had gone up from before. She had been restarted on her statin drug, rosuvastatin, at the time. And so the other tests were, renal function was fine. So she didn't have any other end organ damage other than the mildly thickened left ventricle, stiff left ventricle with a normal ejection fraction. So that's classically what you see with hypertensive heart disease. So she was started on the defined plant-based diet, food level 0 to 4B. You can go to our website for details on that. We talk about the food classification system there. montgomeryheart.com/food classification system. And it gives you details there. But she was then started on a time-restricted eating protocol. Now, I did another show on time-restricted eating protocol. Some people refer to it as intermittent fasting. And we talked about some of the data there. I'll kind of reiterate some of the points we made in that show tonight. And she was then started on infrared sauna treatments. And we have a protocol where we'll put them on a 20 treatment protocol where they'll do Monday through Friday for the first 10 treatments. So they'll do, 2 weeks where they're doing 5 days in a row. And we ramped them up. So we'll start them at, I think, either 5 minutes or 7 minutes, and then ramp them up duration and also ramp up the heat. So we'll start maybe 130 degrees Fahrenheit, and we'll get them up to, by the 10th treatment, if they tolerate it, they're up to about 160 degrees at 20 minutes. And so we go that route, and we monitor them, because we'll get a blood pressure usually at baseline and 5 minutes into the treatment, regardless of how long they go. And I'll show you some of those numbers. So this is a graph of an overall trend where we see back in 2019, so it's about a year and a half. And if you can really look, the systolic numbers and the diastolic numbers, of course, it's a stock market jagged edge, but you can see there's kind of a downward trend, an overall downward trend there. It's an overall downward trend. So, and you can probably find episodes where she probably fell off the wagon here. She may have detox here and maybe fell off the wagon. And so there are bumps in the road. But one thing I want to emphasize, that there was an overall downward trend without any significant medication adjustments over this time period. And I think that's an important thing to consider, because even someone who, who's back and forth and she's not 100% all the time, the influence of having done detoxes in the past, I think, has made an overall impact, not only due to the fact that she's eating detox level food all the time, but I think it's impact her consciousness of what she's eating and so on. And we've seen this in other patients. So even though they're not following our recommendations to the T, we're seeing an influence on their overall health. Decrease in hospitalization, decrease ER visits, and an overall improvement in their numbers, even though it's not ideal. And so I just wanted to kind of point that out overall. So let's get into what we did and what happened. Now, this graph looks a little busy and confusing. I'm going to walk you through it, but I think it's important to think about. And then the reason I'm getting into some of the messiness is because oftentimes it's easy for me to present a case where the patient came here and the blood pressure was here, and then we did some magic and then it's down here and everybody's applauding and all that. But it's not always that simple, because you get into it and you're seeing them day to day. But in this graph, I should have made this red, but this is February 28th, and this is the first day of infrared sauna treatment. And these are systolic blood pressures. And you see, like, when you see the treatment start, it kind of goes up, the treatment, and we didn't really change our medications much here. So the first few days, day 1, 2, and 3, the blood pressure goes up. In fact, sometimes you see blood pressure go up the first week before it started to come down. But she started having some decreases here, and I'm going to show you some before and afters. And some of her blood pressures at home are even lower. This is what we're getting in the office, which are a little bit higher than what she's getting at home. But based on what we saw at home on the 4th, so this is like day 5 of a treatment, we actually stopped the Darby-Chlor and put on a Darby. So we took the diuretic out and put on the Darby. So we essentially reduced one medication, and then the carvedilol was decreased not to 25, but to 12.5. It was at 25, it decreased to 12.5. That's a typo there, so put 12.5 there. And so we made medication changes here, largely because she had some lows. And again, we were concerned about her bottoming out. Frequently, after you make medication change, you do get some sort of a rebound, which we saw here. We weren't surprised with that. So the systolic pressure went up to 152, and it bounced around a little bit. We decreased the metformin at this area, at this point here, and then we started getting drops. And as recent as the day of this presentation, we made other changes. We decreased the Darby from 80 to 40, and we stopped the metformin. Her blood sugars were very low, and there was no need for it. Again, a lot of this was influenced by blood pressure measurements we were seeing at home, plus the before and after. And I'll show you some of those. Here's the diastolic blood pressure measurements. Again, this is where infrared treatment was started. Again, we got this rise here, and then it came down. We were getting some measurements at home, so we made the decision to decrease it. We didn't want to bottoming out, getting dizzy. She got a rebound increase. It came down. Metformin was changed here, came down even more diastolic. So you see the diastolic changes pattern similar to the systolic change. All the while she's on now I found out she wasn't doing the time restricted eating. She's going to start that today, but she was on the food prescription 0 to 4B. and this went up a little bit, but again, some measurements at home influenced this change here. And so we decreased the EDARB at this point. So here's some before and after sauna treatments. Now you can see here, now these are only sauna treatments, so we don't go as far back in time. Here we go back, and I probably should have pointed out, I just gave you some reference number baseline in the early part of February before we started any of this. Her systolic pressure was here. So she had started the food prescription by this time, so that led to that drop initially. Same thing, the diastolic. She had started the food prescription before the sauna therapy, and that led to that drop there. So I just want to point that out. That's kind of a baseline. These are baseline measurements here and here. So now if we look at only when we're doing the sauna therapy, this is before the sauna treatment. So we measure blood pressure before they get in the sauna, and we measure after. We actually measure one midway and then one after. And this is showing before and after. So before and after, not too much difference here. A little bit more difference here, a little bit more difference here, a little bit more difference here. But you're starting to see a bigger difference in the before and after sauna. Here you kind of plateau. But again, we've made medication changes here. But you're seeing a significant drop in the effects of the sauna treatment itself. And that's part of what influences our changes, because we've had some patients, pass out. Of course, we observe them closely, pass out. We lay them down, they come to. And it's rare, but it can happen. That's why we do medically supervised sauna. And we tweak their medications while we're monitoring them. And we have a pretty big drop here. So you have pretty big drops, with the sauna treatment. Similarly here, notice the diastolic goes up. Now this could be because the patient's not drinking well, because we have them drink a lot of fluid before, at least about 1.5 liters of hydration before, but sometimes they don't do that. And so this could be dehydration. But after this first few, most of the times you see it go down. One exception here, it goes down after treatment. So, and sauna does mimic exercise. So there's a physiological mimicking of exercise. Heart rate goes up. So there's probably some vasodilatory effects. And during the sauna, we do know there's data showing that there's an increase in nitric oxide production. And so that's in part why you're getting a significant drop in both systolic and diastolic blood pressures during the sauna treatment. But we see that significantly with her. And the weight goes down. Now, I did, point out the weight because, she's on the intervention. People have shown, people talk about, well, weight loss contributes to these things. And we actually have data showing that, as the weight loss doesn't directly contribute to the blood pressure reduction. I didn't show any of these graphs, but in our publications, in our scientific publication, we showed how on the detox on week 3, the blood pressure actually goes up while the weight's still going down. And so the trending of weight and blood pressure is not matched over 4 weeks. And we've shown that for almost, over 15 years in our data and some of our recent publications. But here you do see significant weight loss. Obviously, she's eating, healthier and on a detox regimen. And so this is really over, she probably started here. So we'll say 15, 20 days, 10 pounds or something like that. So anyway, 10, 12 pounds. So, that's what we have in terms of this case presentation. So a couple of points I'd like to make are the following. This patient had, very significantly elevated blood pressure. She was clearly well within the class 2 hypertension, despite being on really 3 medications. She was on a combination pill, edarbi-chlor, this edarbi plus chlorthalidone. And these are very potent antihypertensive medications. She was on carvedilol. Now, one could argue, calcium channel block would have been more effective, et cetera. For some reason, she had some problems with calcium channel blocks. I don't remember specifically, but long story short, she was on 3 pretty good antihypertensive medications. And despite that, had a very significantly elevated, blood pressure. So instead of adding a 4th or 5th or 6th medication, and knowing that she was a willing person, willing to undergo the detox, we prescribed the food intervention. But in addition to that, we prescribed time-restricted eating, and we prescribed infrared sauna therapy. So there's 3 therapeutic interventions that were brought on board. So it's not like we were just saying, okay, we did nothing. In fact, we provided a very powerful intervention. And in just a matter of, you saw from the graphs, in less than 2 weeks, we were having significant enough drops in blood pressure where we were reducing medication. And so, as I alluded to earlier, there's a physiological process that undergirds hypertension that you have to address first and foremost. I mean, I could have given her a 4th or 5th medication and gotten the numbers down. I mean, we could have done that, but she may have had worsening side effects, maybe swelling, maybe it could have been some underlying hepatotoxicity that we wouldn't pick up for months or years later, or renal toxicity we pick up months or years later. So we could have always done more in adding medications. However, the intervention she needed was a nutritional intervention, including food prescription and time-restricted eating, as well as infrared sauna therapy. And there are a number of patients that we're seeing is having great success with infrared sauna therapy. In fact, we just purchased our second sauna for the office, where because we're so busy and it's a little bit backlog. Not like we have 1,000 people, but it's enough that we needed a second one because we're finding it to be a very effective therapeutic intervention. And so oftentimes we'll get individuals where we'll treat, monitor them, help them wean the medications, and then we will maybe have them go get, buy a sauna. I had a number of patients buy a sauna at the house. And we've had some other patients, join the gym and do sauna. And once their levels are controlled, then they can safely do it, somewhere else. And as you know, it can be pretty hairy with the blood pressure bouncing around and with us having to adjust the medication. So if you do this, you want to do this, with your doctor, on your doctor's supervision. Tell your doctor, get a sauna, put a sauna in your office so you can help control the blood pressure better. And also at a restaurant while you're at it. But anyway, so I'm going to pause right there. Why don't we take a quick break? And I know hopefully you guys have picked up on some of the questions, and we can get to the questions. I want to get y'all's opinion and comment after the break. So let's take a quick break, and we'll be right back to finish this conversation. Okay, we are back. We're back. So anybody, I'm going to stop talking and get y'all's comments, Dr. Atkins, Dr. Palmer, your thoughts on this approach. You're on mute, Dr. Atkins. You're on mute.
I'm sorry. Great presentation. And I think when people monitor their blood pressure and give reports, I guess maybe if you do it relatively at the same time, like before their medication, or which blood pressure was after their medication, or if you want to do one in the morning, one in the evening, but it may not be exactly the same time, but that may have some factor in the results, of interpreting the blood pressure there. That was one point I wanted to make. But I did see in the comments, Clean V22 2013 said, can mild heart thickening be reversed over time? If so, how long would it take on a plant-based diet program?
That's a great question. So we published a case series. Now we're going to look at, we actually are rolling out a study almost as we speak. We haven't, we're going to look at this at the biochemical level. What I can say is this: we had a case series of patients with heart failure. And in that, we had MRIs of the heart before and after. And we saw a significant amount of left ventricular regression thickening of the heart muscle. We had one person's heart decreased by 100 grams in size, which is humongous. Normal heart's about 200 grams or whatever. And this heart was enlarged, it's dilated and thickened. And so that case series, again, there wasn't a large enough people say, yeah, we can do it. But I'm fairly confident that you can see LV regression. How long does it take? I don't know. But in this population, this case series of 3 patients, we saw it on average of 78 days. And so I think with a plant-based diet, you could probably see significant LV regression. If I had to guess, and again, I don't have the data, I'm working on the data, so give me some time. But if I had the data, if I had to guess, I would say you could start seeing significant regression in 4 weeks. The reason I say that is because we're seeing a lot of biomarkers, particularly biomarkers associated with inflammation, that changes very rapidly. And a lot of LVH may be due to these acute inflammatory processes that are causing hypertrophy. So I think the answer is yes. I think it can happen. We've seen it happen, and we're working on the data to give more definitive evidence. And I think somewhere on the order of a month or several months is probably the time length. Good question.
Okay, and Rosetta Kincaid, did you see that one? Oh, you want to do that one first?
Yeah, so this one, can some blood pressure medication increase blood pressure? Currently, my doctor has me on 3 medications, still blood pressure. That's a great question. It's my quick answer is I think so. I'll just put it that way. And the reason I say that is because the following. Oftentimes, doctors will prescribe diuretics. And we had this patient on a diuretic for hypertension. So let's say, for instance, someone have elevated blood pressure, they have a thick heart, and they have a stiff heart. If you have a thick and stiff heart, when I say thick and stiff heart, I'm thinking about the left ventricle. It takes more pressure and more volume to fill that chamber. So if you think of yourself trying to inflate a balloon, if you think of a balloon that has a thin rubber, balloon, you can blow into that very easily. Let's say you're blowing into a balloon that's rubber, it's about as thick as a tire inner tube. It takes more pressure and effort to blow and inflate that balloon. The heart is a similar, there's a similar physiology going on with the heart, particularly the left ventricle. If the heart left ventricle is normal size and it's not stiff, meaning it has normal pliability, then the amount of pressure and volume is going to be less to fill that chamber. If the heart is thick and stiff, the more dehydrated you are, the less circulation, less filling you're going to have. And so the less circulation, so less volume inside the left ventricle, the less volume it can eject. The less volume it ejects, the less circulation around your body. When you have less circulation, that means the kidney is seeing less perfusion. When the kidney sees less perfusion, the kidney says, oh, we're in shock. So it sends out hormones like renin to trigger the renin-angiotensin system to cause more constriction. So paradoxically, you can be given an antihypertensive that's a diuretic that decreases volume. Reduction of volume decreases flow. The decrease of flow tells the kidney that we're in shock. When the kidney says, oh, we're in shock, then the kidney sends out hormones to constrict and increase blood pressure. So yes, antihypertensive can contribute to hypertension. So that's why when I think of managing patients, I treat them physiologically. I don't say, oh, blood pressure high, medication. You have to look at LV function. If someone has hypertension and diastolic dysfunction with LVH, I'm going to try not to give them a diuretic. That's the last drug I'll give them. Now, yeah, sometimes I do give them that, but that's why we like to go with nutrition, try to minimize medications in general. But yes, blood pressure medications can elevate theoretically, and I just kind of explain physiologically how. But yeah, 3 medication, blood pressure 150 over 90. You need to look at some alternative approaches and not just the blood pressure medication. And so talk to your doctor about that. Anything else I'm missing? Any comments you guys have?
Yeah, I just wanted to say when we're layering different blood pressure medications, but we don't want to forget the power that you presented about the diet. And so a lot of times we put the power in the prescriptions and we don't make a lot of changes in our diet. But the more we eat a cleaner diet and more plant-based and increase the raw, we see wonderful things happening with the blood pressure. So I encourage that the person that was saying that, 3 blood pressure medications, we can take back some of our power by changing our lifestyle, our diet, and exercise, regular exercise. Mild to moderate. We're not asking you to jog or to do anything out of the ordinary, but just even walking would be a good start. But that can have a powerful effect on the blood pressure. So I think as conventional medicine, we don't always emphasize that. We just keep layering more medications. And so I just wanted to make that point.
Can I add something?
Yes.
I didn't know you're going to switch the screen, but one of the questions on screen from Zena is actually something I kind of wanted to address. So I've had family members that I've introduced to the plant-based world, and not necessarily raw, so not 0 to 4B, not your system, but just plant-based. Let's get them there first. Who have diagnoses of hypertension and are taking medications for that. Now, over time, because of the change in how we're eating, weight was lost, and so blood pressure is going down. This is what I'm saying. But when they go to the doctor, they're anxious, and so the blood pressure is looking like it's elevated. And so one of the questions on here was, how can blood pressure be managed if triggered by anxiety? So every time they go to the doctor's office, the doctor is saying they need to continue the same dose. Then at home, some side effects of feeling lightheaded and dizzy are being reported back. But, the connection, because your doctor is telling you everything is fine. And then you come back home and you feel dizzy and the pandemic is going on. So, you put it on many other things. Maybe I'm just stressed, blah, 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 blah. Because the thought never comes up that maybe my blood pressure has dropped, because every time you go to the doctor, it's not. And then, you're being kept on the same medication, which means when you're walking around the house, it's low. Yeah. So something for that question is, that's why we need to check it at home. And check it at home, like Dr. Atkins said, on a regular basis, same time, morning, before meal, after meal, at night, whatever is your time. And then when you go to your doctor, you take that to your doctor so that he can compare what you look like in the office versus what you look like at home when you're moving around before bed and when you first get up in the morning.
Yep. That's important. I mean, taking it home is very important. And I think it goes along with the whole process of, being in charge of your health. You want to monitor your health. So if you have a diagnosis of hypertension, you should check your blood pressure at home, just like you monitor your blood glucose at home if you have diabetes or those types of things. But the anxiety is an issue, and you treat anxiety by a lot of different ways. There's meditation, there's exercise. There are a lot of things. You're not watching, the news. We talked about different approaches to managing, prayer, meditation, those types of things. And I think those things go a long way toward calming you down. And the foods you eat. I mean, we've seen in the course of thousands of pages we put on detox, and we don't do anything special for the anxiety. We've had many patients come off of anxiolytic medications, antidepressants, et cetera, just by changing the biochemistry of what they eat. Now, I'm not saying that's the only thing, and that's the case for everyone, but that's a foundational thing. And then beyond that, you want to do things to manage your stress. And in our practice, we do digital health, where we manage a lot of patients from home. So we're looking at a lot of the home blood pressures. We have a technology where we provide a blood pressure machine for them, so they take it at home and it uploads to our data, so we know that the machine they're using is good. and the measurements are being uploaded to our system. So there are lots of technology and capabilities out there, and then you have to look into your environment and see, okay, what's causing anxiety? Like I say, going to the doctor may cause anxiety, and so maybe you go there and you relax for a while and what have you, because oftentimes people are just anxious, and doctors are. And I was talking to a patient last week, and they go in and they're used to the doctor, you give them some horrible news, and it's all, I mean, like it's just the least abnormalities, like, well, you need to take this medication, or this is bad, that's bad, and unfortunately we're not. I mean, we're the stressors, because we say, oh, you're gonna die, or you have dead, or whatever the case is, or you need medication for life, or you're in trouble, as opposed to giving an optimistic outlook to things. And I think we need to kind of work to do that. Of course, I'm not preaching to the right people, but anyway. But it's a problem. So the anxiety can be a problem. It's something that you have to be aware of and try to manage.
In relation to what you're saying, somebody asked about the best blood pressure machines to use at home. And I prefer that you speak on that because that's your area. But what's the best measurement type of measuring device?
So historically, we've used the Omron device. I mean, they don't sponsor the show, but the Omron machine, either on the wrist or the brachial blood pressure. Having said that, there's a lot of data saying that the brachial blood pressure is not really ideal. We have a device that, two types of devices that can measure what's called central aortic pressure, and it looks at the waveform. So it measures the waveform, the radial artery, and it's like having a catheter up in the aortic root, and it gives you the pulse pressure, the difference between the systolic and diastolic pressure that's measured like at the diacrotic notch. And so that pulse pressure is thought to be more important prognostically, because sometimes you can have a elevated brachial pressure, but the central aortic pressure is normal, or vice versa. And so we're starting to look at that now. But to answer the question, for the practical purposes, we tend to tell our patients to get the Omron machine. That's been found to be good in our practice. There may be other machines that are good that we haven't looked at. But from my understanding, most of them are pretty effective. The wrist machines and the cuff machines are okay. If you have a very big arm, you may want to go to a wrist machine, because it may be hard to find a very large cuff for someone with a very large arm. And so, those are basically the things that we look at. What else is this? Did I miss anything? There's some other stuff here. Somebody asked about CoQ10 and CoQ10 and IP. I don't know about IP6. Anybody know about CoQ10? Is an ubiquinone, and it improves mitochondrial function. Now, there's not necessarily a direct effect, but by improving mitochondrial function, improving cellular function, you're going to get better physiology and function of heart, vascular tissue, and the like. IP6, I don't know the effects of IP6 on blood pressure. Anybody know that?
I don't know direct effect. IP6 is inositol from like brown rice, but there's anti-inflammatory effects and that nature, and even cancer-fighting properties. But I don't know a direct effect with the blood pressure. But always my Dr. Floyd always says at our office, you can take a lot of supplements, but if you put all the supplements in a toxic waste dump, it's not doing anything. So we want to make sure our body is clean and detox and eating clean food and healthy food. But we see fabulous things happening when you increase the raw. I mean, and that's why it's important to monitor, because blood pressure comes down, and many times I have to give my patients a sliding scale. If it's below a certain amount, when not to take it or when to take it, because you don't want them to get woozy. But we do have the power over our blood pressure and hypertension, not just the medications. I'm not saying not to take the medications, but be mindful when you make these major changes in your diet and exercise, you can see major changes in your blood pressure, and you may need less. So you need to have that discussion with your doctor.
Yeah, no, that's a great point. And
that's what happens in the pediatric world. I mean, this is, I know geared towards adults, but in the pediatric world, we also see children coming in with elevated blood pressures. So just to be more direct, the averages can be anywhere from the mid 80s all the way up to the 120, 125. Systolic and diastolic is like 50s all the way up to 80s. And of course, the lower numbers are in the newborns and in that first year of life. But so what I mean by that is we don't expect a 19-year-old or 18-year-old to be 90 over 60. That would be, like I said, a younger child. But one of these questions here that you have down here actually right now, about the weightlifters living at a blood pressure of over 300, and maybe you can assist with this, Dr. Montgomery, because when I've traveled out of the country, I do see people and done some missionary, done some work, medical mission work. I do see kind of blood pressures of 200s over 100s, and that is not that is common. Now, they've been diagnosed with hypertension and they're supposed to be taking medicines, but sometimes they are not able to get those medicines, so they haven't taken their medicines in 5 years, but they've been living perpetually, I guess, at that level and not really feeling anything. They're coming to us because they want to know, should they do anything at this point? And so it poses a question: if you've lived at 200s over 100s for 10 years, do you want to correct that? And the reason I say that is because I know somebody who said that her mother came into the country to live with them. Her blood pressures were 200s over 100s, and which scares us here. And she was immediately started on medicines, and she immediately not immediately started on medicines, like they put her in the hospital and gave her IV medicines right then, but they dropped her pressures. But ultimately, it ended in her demise because so many other complications started happening in that case. And it all started with them diagnosing her and feeling like they had to get that blood pressure down fast. But was that necessary?
Yeah. Well, I mean, the comment about the weightlifter, I mean, generating blood pressure over 300, that's extremely high. And they said with no consequence. I mean, you have to put that in context. Is this an isolated blood pressure while they're doing, some anaerobic exercise, lifting weights, and the blood pressure comes down? If your blood pressure is over 300 nonstop, I think you're going to have some problems. I see patients here with blood pressure of 200 over something and asymptomatic. I mean, it's not just in other countries, it's right here in the United States. We see a lot of people with, that's why they call it the silent killer. You see people with elevated blood pressure for, more than a decade. And it's frequently what we see, it's associated with, in-organ dysfunction. I don't have data from other countries. I don't know what data they have, et cetera. So I'm not going to try to speak to that. Certainly in the United States, we see, hypertension is a problem. We do know that cardiovascular disease worldwide, I mean, it's the number one cause for heart disease worldwide used to be Chagas disease. Now the number one, the cause of disease of heart failure worldwide is cardiovascular disease, atherosclerosis and hypertension. So, there's a universal aspect of these diseases that we're seeing. And so the same thing we're seeing here in the United States, we're seeing in other places, because the prevalence of heart failure and the underlying causes of heart failure has been, universalized. And so, So as I said before, the elevated blood pressure in and of itself is not the only problem. It's a signal of underlying physiological abnormalities. I think human beings' physiology is very similar, throughout. There are some genetic differences, as I pointed out, but I think, if we assume hearts in other countries are the same as hearts here, and blood vessels are the same as blood vessels here, there's some variation of genetics from one race to the other, but by and large, you would think that these numbers, 120 over 80 is probably not a normal number. Now, when I say 120 over 70 or 116 or whatever the case is, that number is the result of other things. So if somebody has a blood pressure that's 220 over 140, then you say, well, is their adrenal gland off balance, or their thyroid adrenal axis off balance? The blood vessel is the smooth muscles. Is there fibrosis in the vascular smooth muscles? There, fibrosis or hypertrophy in the left ventricle, et cetera. So, you'd have to show me data that shows, people elsewhere, normal blood pressure 220 over 120 over the course of 20 years, no LVH, no diastolic dysfunction, no renal dysfunction, et cetera, no atherosclerosis. I mean, I just don't know, but I do know worldwide the number one cause of heart failure is, atherosclerotic disease and hypertension. So, that's sort of what we have to deal with, from an epidemiological standpoint. So a blood pressure of 300, I mean, maybe they can get away with it in short duration. If you're a power lifter, that may not be unusual for power lifters. And if it's only transient, then there's no consequence there. But if the person's living with that blood pressure or having that blood pressure elevation all the time, then we'll have to look at that. And you can make that same argument for football players. But then look at what's the lifespan of power lifters compared to the average person. The lifespan, I don't know the answer to that question, by the way, but the lifespan for NFL linemen used to be average age about 55. That was their lifespan. So they lived to 55, and they're definitely power lifters. And so I would imagine power lifters may not be longevity kings and queens.
I just like to say something else.
Sure.
That I meant to say earlier, but I saw that question and kind of got sidetracked. But in our children, when they come in with a little bit elevation of their blood pressure, it usually only takes them a very short amount of time to make a correction in what they're eating, maybe join a team. They don't have to be the best player on the team, but just getting active, and it will come down very quickly. It's just kind of getting the parents to encourage them to get active and just change what we're eating a little bit.
Yeah, now I think you're right, and that's a take home even for the adults. And you saw in this patient. Now we didn't have the getting active part, but infrared sauna does mimic the physiology of exercise. So some people say it's a good adjunct to exercise, and if you can exercise, then it's a good replacement for people not able to exercise, freeze for arthritis, etc. And we have lots of patients with arthritis. It helps the arthritis. So, I mean, you start here with, natural eating, time-restricted eating, and also with infrared sauna therapy, in your case with exercise, or both, you can see very drastic improvement in blood pressure. One comment I will make about the eating part, and this is a pet peeve of mine, oftentimes people like, oh, I'm eating better, but then on the weekend they'll say, okay, I went to a party and I splurged. You have to be very precise in your eating. And when you're on, that's why we like to use detoxes for a period of time. You really want to be 100%. And so when you're on a detox, you may be raw for 100% plant-based. And when you come off, you may have some cooked plant food, but you don't want to go into, processed cooked foods, processed fried, sugars and things. So you really have to be very precise with your nutritional regimen. And also we're starting to encourage more people to, do time restricted eating regimen so that you get used to not eating after a certain time of day, even when you're eating at your normal, in your normal regimen. And so I think these are some important lifestyle habits that will help you get off and stay off medication. And I think everybody's goal should be, if you're on a blood pressure pill for your blood pressure, your goal should be to get your blood pressure normal on no medications. And I think, that should be, it's not an unreasonable goal for the vast majority of people.
Yeah, I just like to say that the lady the mother that they tried aggressively to lower her blood pressure. We have to be careful with, especially senior citizens. I know you see it, Baxter, all the time, but like you said, we can't just treat numbers. But with senior citizens, sometimes they tolerate a little bit higher blood pressure, or we don't want to drop their blood pressure at too low because they're depending on perfusion of some of their organs, their brain, etc. And so it can have a deleterious effect, aggressively lowering blood pressure. But clearly 200 systolic was too high. And as you said, Baxter, we're trying to prevent in-organ damages. It may not happen at that moment, but to the kidney, to the heart, long-term congestive heart failure, enlarged heart, stroke. I mean, many times high blood pressure can promote a stroke suddenly, a hemorrhagic stroke. And so those are things we're trying to prevent, but it is a silent illness. Many times we feel okay, but we want to gently lower that blood pressure for, seniors and people higher up in age, but we can be a little bit more aggressive with younger people. And so I just wanted to make that point.
I'm glad you brought that up because I should have followed up. I was intending to follow up, and I lost my train of thought when I commented on what Celeste said. I just want to comment Rosetta Kincaid. So I didn't realize she had said that, but the hypothetical I gave seemed to apply to her. So that was. I'm glad that was helpful. I wasn't trying to make a diagnosis or anything, but that the example you gave, Celeste, about them immediately dropping blood pressure is, and Pam, I think you mentioned that as well. It can be dangerous to drop blood pressure aggressively. One pet peeve of mine, even in the hospital, I give medications, quote unquote PRN. I see patients who come into my office often with blood pressures 240 over 120, 200 over what. So it's very common that we see that. So, and I teach my mid-levels to do the following. One, you take a history and you try to ascertain how long they've had that blood pressure. And if it's been elevated at that level for some time, then they're going to be auto-regulated at that blood pressure. By that, their vascular system, their brains are auto-regulated. So you're not going to aggressively lower that blood pressure. That's number one. Number two, you want to look for signs of end-organ failure. So are you having chest pain? Are you having severe headache, the most severe headache you've had in your life? As Dr. Atkins talked about, the subarachnoid bleed, and so on. Oftentimes, the elevated blood pressure in and of itself may not cause a problem. It may be a signal of an underlying problem. People with strokes and elevated blood pressure, the neurologists, when they're treating a stroke, will not regret. In fact, they will leave the blood pressure elevated because they want them to perfuse the brain. And so it's not so much because if the elevated blood pressure was causing a stroke, you'd say, okay, let's lower the blood pressure rapidly to reverse the stroke. But that's not the case. So we know that the elevated blood pressure in and of itself, by itself, I should say, it's not causing, but there's an underlying vascular problem. As somebody pointed out earlier, the consequences of kill your inflammation, and we talked about that. So inflammation, vascular damage, all of these things that are underscoring our body's biochemistry, physiology, these things are present, and the blood pressure is elevated. And so it's not just, okay, just lower the blood pressure and you're fine. And sometimes we're too aggressive in lowering the blood pressure acutely, and what happens is that you have a problem with what Dr. Palmer talks about. The patient had a problem. They gave her something, the blood pressure bottomed out, and they came back. And that's why, as I showed you in this example, we're following these patients, the sauna, very, very carefully, because the therapy of the sauna and the food prescription can drop blood pressure very drastically. And so we're pulling medication back and let the blood pressure go up because the patient auto-regulate higher. So if you look at those slides, we say, that blood pressure went up to 152. Well, that didn't bother me because I'm backing off on medication. She's getting the therapeutics. I saw another patient today. He's getting the sauna therapies, and his blood pressure coming down. And so we just stopped the medication. It was in the 140s, 150s. So your blood pressure oh, that's fine. I'm okay with that. Why? Because he has ongoing sauna therapy, ongoing nutritional therapy, and that pressure is going to come down. And so to drastically lower pressure too fast is very dangerous. That predisposed to stroke. The watershed areas of the brain are not perfused, and you can have a lot of problems. So I think that case that you mentioned, Dr. Palmer, is one where, they were too aggressive, and oftentimes they will prescribe medications, take medication such and such as needed for blood pressure greater than such and such. I don't really subscribe to that, because you should not be doing PRN, because you can drop it too fast and cause more problems than you're trying to prevent. So somebody asked about a rebounder. That's good. And Dr. Palmer say something.
I just had a question for you, actually, just in the adult world. So if you ever do, when do you start aspirin therapy, if you do? And, or on the other end, when people come to you with their aspirin and you're weaning things off, at what point do you wean the aspirin off?
Yeah, I'm pretty aggressive in weaning aspirin. If somebody's had a previous event, stroke, heart attack, etc., and I don't think they're going to be compliant with the diet, then I'll probably start an aspirin, leave it on aspirin. If I'm worried about it, so let's say if I see lots of atherosclerotic plaque in the carotids or somewhere, I may give, say, what's called dual antiplatelet therapy, and aspirin plus, something like clopidogrel or platelets, as we call it. So we, attack the platelets, because I'm maybe worried about a vulnerable plaque, either in the coronaries or the carotids, et cetera. So it's really on a case-by-case basis. But, the old adage of just give people an aspirin to prevent stroke as for primary prevention is, is fallen by the wayside. And so we really don't do it for primary prevention. The patient in this example is on aspirin plus Eliquis. She had, atrial fibrillation, and we may, look at her cardiac rhythm. If she gets stable on nutrition, we may remove the Eliquis and just leave her on aspirin. Aspirin is shown to have some benefit at 325 milligrams, at least in some European studies. So I may use it in some population, people that don't want an anticoagulant for whatever reason. People have had an event before and they're not going to be compliant with the nutritional regimen. I'm, concerned about compliance, or somebody has, lots of atherosclerosis that's defined, and I'm concerned about them, and I may give them aspirin and Plavix until we can kind of get them stabilized nutritionally. And a lot of those things, some of the things, you ask, well, am I treating the patient or am I treating myself? It's like, and, we do that. I'm sure you guys, I'm just sharing this with the audience, but sometimes we'll do therapeutic things, because there's not a study that points at every particular situation, but we look at guidelines and the data to kind of give us a backdrop in terms of saying, well, there's evidence that this therapeutic agent has helped people in this condition, and we know that these people in this condition haven't undergone drastic lifestyle changes, but we know that they can benefit from it. But I try to get people on zero medication. So I know that's a little different than the question about aspirin, but I try to get them off aspirin as soon as I can, and to the greatest. And if they comply with detox, intermittent fasting, sauna therapy, exercise, fresh air, sunshine, all those things, and if they have an arrhythmia, if the arrhythmia is under control with that, or if the atherosclerotic plaque, we check biomarkers that look for vascular inflammation. We check ultrasensitive troponin levels. So we're looking at biomarkers that says, okay, your vascular inflammation is down to normal. And if it stays that way and the lifestyle is good, then I'll say, okay, we'll stop the aspirin. So we're looking at a lot of different things that will help us make that decision. But we work very, very hard to reduce medications and eliminate medications, because I think medications is in and of itself, polypharmacy is a disease, and so it's so why are you trying to treat the other disease? Give them this disease, treat the other disease. So, Any final comment? Great questions. The rebounder can help, I think. And let's see. Last question: what would be a good routine for rebounding for the heart? Sorry, I forgot that part. Anybody ideas on rebounding? I think a couple of times a day. I don't know.
Yeah, I think rebounder is just, walking or bouncing, but I just caution with the rebounder, making sure that you're not dizzy, no dizziness or, reasons to, fall off, hit your head, etc. Some rebounders have handles on either side, but just gentle jumping up and down or shuffling the feet while watching TV, etc. But like walking, you just build up your stamina. So you may start with 5 minutes and work up to 10, 15, eventually 30, could be an hour, but you just work your way up. But it's just that mini trampoline, but that can be a way to have cardiovascular exercise. I also just wanted to say, if somebody has hypertension, we really shouldn't be eating potato chips, French fries, fried food, fried chicken. I go to, family reunions, repasses, things like that. And that's what people are eating. And, 75% of people have hypertension and diabetes. So I just want to say, because people think they'll take their medication, but they can still eat those, but those have terrible effects to your blood pressure, So I just want to be on record saying that.
I want to be on record for seconding that motion. Do we have a third, Dr. Palmer?
Yeah. Yes.
But it's interesting because you said that, but it's people talk about their cheat days, right? By the time you've been diagnosed with a chronic illness and you've used up all your cheat days, it's only detox from here on out. So your cheat days are over.
The party is over, right?
The party's over. You've had more than your share. It's time to give some of it back, actually. JW came late. Patient who 2 years later still have high blood pressure, like a seemingly excellent diet. The operative word is seemingly. So what I will say is this. If the diet is excellent, it needs to be more excellent. I mean, if your blood pressure is high despite being on a medication, what do we do? Increase the medication dose. So then if it's high to being on one level's diet, then you need to increase the nutritional dose. And we've done a lot of different things with people, such as intermittent fasting, prolonged fasting, put them on a 1 meal a day, 24-hour fast. So there's a lot you can do with nutrition that can really get blood pressure down, sauna therapy, and so on. So, we haven't seen anybody yet we've had some challenging patients. I'm not saying it happens overnight, but if they do the right thing, we've seen the blood pressure come down. And if not, you may have to look for secondary cause. And some people have secondary hypertension. So, renal artery stenosis, pheochromocytoma, adrenal gland insufficiency, all these things. So there are secondary hypertension things you need to look at. But you need to be with a doctor who looks at every aspect of what blood pressure is, not someone that's going to throw medications at you. So anyway, we've had such a great time. We've gone well over an hour. I don't want to keep everybody late. My colleagues, I know they're very busy. You guys, thank you very much for your insight. I'll see you backstage. I'll close out. So if you like this information, should have said this a long time, give us a thumbs up. We have a few thumbs up and or some love. And also, if you haven't subscribed, please subscribe. Thumbs up, thumbs up, thumbs up, subscribe, and share. This information, I think, can be very valuable. We talk about a lot of different things, pandemic and all that stuff, but high blood pressure has been killing people for a long time, and it's going to be killing people for a long time if you don't get it under control. And there's some really simple things you can do that require discipline, particularly in terms of the foods you eat. And you have to get serious about this. As Dr. Atkins says, you shouldn't be eating. It seems obvious, but I'm glad she pointed that out, because we shouldn't be eating these bad foods. And we have high blood pressure and we eat these bad foods, and we should avoid them like the plague. And so take this condition seriously, take your life seriously, take your health seriously. It's not a game to eat bad food. It's not a joke. It's not funny. It's these things are, they're not only could they kill you. Killing you is probably the least dangerous thing. It can, cause amputation, cause kidney failure, cause, heart failure, but then liver damage. And So it potentiates illness as well as death and suffering. So you don't want to torture yourself. And getting on a healthy diet, even a raw plant-based diet, you'll learn to love that. There are lots of delicious foods that you can find, and it's a diet that you will then learn to love, and it'll diet that will love you. So keep that in mind. But until next time, keep it fresh, natural, and live.